We are good to go, sir.
Yes. Good evening, all. Myself, Dr. Kiran Varma, working as head of the department, Emergency, Yashoda Hospitals, Somajiguda. So I'd like to welcome you all on behalf of Yashoda Group of Hospitals for this series of webinars connected by Emergency Department on every Friday. So as you all aware that we will come up with interesting topic every week. So this time also we have come up with an interesting and a unique topic. To enlighten and particularly this topic, we have Dr. and Professor C.V. Raman sir. Raman sir. So who is Emeritus Consultant, Department of Emergency Medicine, Singapore Hospital, Singapore, and also Clinical Professor Yong Lin School of Medicine, National University of Singapore, Clinical Professor Duke-NUS Medical School, Singapore, and also Chairman Emergency Medicine Examinations Committee, Division of Graduate Medical Studies, National University of Singapore. So topic for today is from fragmentation to the integration. Even myself, I'm interested and excited to listen to this particular webinar. So thank you, Dr. Anantharaman sir. Please take out the forum.
Thank you very much.
Sir, your voice is not audible.
Right. Let me just sorry.
Anantharaman sir, please share your
Yes.
PPT.
Right. Okay. Right. Can you see the screen?
No, sir. We're unable to see it. Please
You're
share.
unable to see it. Okay. Let me turn this off and start again.
So I think there is some small interruption.
Small interruption. So we'll try to rectify it. I think
Yes, sir.
severe, Anantharaman sir has some problem. Okay. Yes, Anantharaman sir is back. Anantharaman sir, is everything okay? Please unmute, sir. Please unmute.
Right, okay. Right, can you see the screen now?
Yes, yes, sir. We can see the screen now.
Okay, very good. A good evening to everyone. First, I wish to thank the organizers for giving me the opportunity to talk about this particular topic about fragmentation and integration in emergency medicine. And so I think this is an opportunity for me to whine quite a bit about the various issues that we have in emergency medicine and why we are not an integrated body yet, and why integration is so very important. But before I go further, just let me define a little bit what I'm referring to. What do I mean by fragmentation or integration? By fragmentation, I'm referring to the process, the act of breaking up into smaller groups, into smaller fragments that don't really interact very clearly, very well with each other. While integration is just the opposite, because integration refers to the act of combining, of making things work, of integrating, of linking various aspects of the process of patient care, especially when it comes to emergency care. So in my talk, I'll first talk about where we are now, why we are fragmented, how fragmented we are. Of course, we'll come back to why we exist in the first place, if not for our patients, and why have emergency care. What is this about so great about this emergency medical care system that we all exist in it? And of course, no talk is complete if we don't give examples. And because I'm most familiar with where I come from, that is Singapore, I'll use Singapore examples as much as possible. And then we'll see, let's see what an integrated system can occur and how we can bring this about.
Okay.
Right. Now, if
Anantharaman,
I take...
sir, sorry to interrupt you. We're unable to see your PPT.
I see. Okay. Let me stop share and share once again.
Yes, sir.
Can you see it now?
Yes, sir. Yes, sir. Now we are able to see.
That's good. Let me just... Right. Is this clear now?
Yes, clear. Perfect, sir. Thank
Very
you.
good.
Thank you, sir.
I'll use the example of Singapore because in Singapore, our first emergency department was set up in 1948. That's 75 or more than 75 years ago. And we existed almost alone. And in the 60s, early 70s, there were a few emergency departments that were set up. Initially, they were not 24/7 EDs, but only worked in the day hours. But in the early 70s also, our ambulance service became integrated because the hospital non-trauma ambulance service run by the Singapore General Hospital, which is where I work, combined with the public trauma ambulance service, we formed the first national emergency ambulance service in our country. So that, and we thought that was a very good thing. And then in 1980, the state gave us recognition as a medical discipline, as a medical specialty. And wow, things were coming together, and we even began to organize courses from 1985 onwards. Then we even set up a committee getting all the public emergency departments together around the same table, formed a coordinating committee, and 3 years later, all right, even our nurses formed a coordinating committee so that the development of medical care, nursing care for emergencies, all right, could be a coordinated process. And we thought we are superb. We are very integrated. In 1989, all right, we went through a process which we call restructuring. Maybe it's not very important, but it meant what was important about it was that each hospital no more came directly under the health ministry, all right, but became fairly autonomous. Now, and our concern was that with this autonomy, we may split apart. But in 1993, we formed our national society, the Society for Emergency Medicine in Singapore. And if you think about it, if you look at India and Singapore, the national organization in India is referred to as the Society for Emergency Medicine in India. All right, and at some other occasion, I'll tell you how these similarities came about. In 1995, we even began an advanced diploma in emergency nursing program for the country. Again, a very integrated program, undergraduate program in 1996, right? And our national exams on a national footing in 2001. Now, but what happened after that? After that, we even formed a college, a chapter first, which became a college of emergency medicine for the whole country. All very good. But in 2010, all right, we started the US residency style training system and separate residency programs. And the moment the training programs became separate, the national committee that we had to coordinate emergency care was closed down. It was dismantled. So opportunities for us to meet together, to interact, and the process of disintegration, fragmentation started. So, you know, we have gone through a process of integration and fragmentation. Now, is that a good thing? I think, at least I don't think so. And I think there are many who agree with me. And in an effort to bring all these back together again, we did ask ourselves the question whether as a national society, as a community in the country, do we truly know what is the burden of emergencies in the country, where they occur, why they occur, how they are managed, right? What are the resources at our disposal, and what happens to our patients? Do we have national data? And this is the problem, that once we become fragmented, we talk less to each other. So where are the resources that we have, all right, for the care of emergencies? And this is not just in Singapore, this happens all over the world. In many places in the private sector, all right, there is primary care being provided. There's also in the public sector primary care being provided. Do the private sectors and the public sectors talk to each other? Very often they don't. And here I'm referring to primary care because very often primary care is a source of many referrals to emergency. Of course, there are many who come to emergency on their own. And we often ask ourselves, do we have first responders in the country? What do we do? And usually it's very difficult for us to do about it because each one of us today exists in a separate hospital. We work only for the hospital from our institution. Very seldom do we see all medical institutions in a country coming together to see how can we deal with the lack of first response in our country, in our community. How do we address the delays that occur? What delays? For example, patients with an acute myocardial infarction, patients with stroke, they come to us beyond much later than that narrow therapeutic window that exists. So late, we ask ourselves. Now, but that is again for the pre-hospital part. Then within our emergency departments, again, is appropriate use being made of our emergency departments, or sometimes it's misuse being made. But we often pride ourselves and state that, oh, we in emergency medicine, we are all right for the health services of the country. We take in everyone. We seldom turn away patients. We don't turn away. But why are we saying that? Is that an excuse for even seeing non-emergencies in the emergency department? Is that an excuse for earning revenue from patients who don't require much care? And this is something we have got to ask ourselves. Because in all our countries, we have primary healthcare systems who should be dealing with the primary care. Rather, most emergency departments around the world see a fair bit of primary care. However, the staff who work in emergency are trained to manage emergency. yet many of them end up tending to primary care, which is a waste of resources. It also shows the resources in the country are being not well utilized. There's no proper right siting of care. How about staffing in our emergency departments? Staffing is limited by budgets. It is limited by the number was, and because of those limitations, very often our doctors struggle to manage large patient loads. Many come to us, and therefore we refer to crowding. Perhaps more crowding. Emergency departments should not be crowded. There are many reasons for the crowding. We won't go into it in all aspects. Just to say that there is an input problem, there is an ED process problem that we call the throughput. And of course, we all know that also access block issue, that is the output. And today, in my hospital, as in many hospitals around the world, access block is one of the major contributors to crowding in the emergency department. And sometimes our colleagues in the inpatient department ask us, are we admitting too many patients to the inpatient area? Too many, such that we fill up all the available beds. When the really sick patient comes along, right, there is no bed for the patient. That patient ends up waiting in the emergency department. And as you all know, all right, the longer patients wait for beds, the more crowding there is in the emergency department. That is not a good thing for our patient, right? I've seen notices, all right? Please excuse any inconvenience that you may experience. We are trying to improve our emergency processes. Does that help? No. And practice. How many of us have considered what do our patients have to say about it? What do they think? Or how much say do they have in each of your institutions, in each of the areas where you work? How much do they have over the process management in your department? Because, well, no, they don't really have. So they are the major stakeholders. Then let's ask ourselves, should we not begin to give them a say? Let's see what they have. Maybe they may have ideas that we can learn from. In almost all our countries, none of us, in spite of many years of being in emergency medicine, all right, we don't have a really comprehensive trauma registry. Now, some may disagree with me on this. Yes, we have a national trauma. We do in Singapore. We have a national trauma registry. But how much information do we learn from this? How much of the lessons that we can potentially learn from this registry do we put back into the emergency department patient care? And that's what we need to ask. It's no good just having a registry. It's no good having a cardiac registry unless we learn from the data that's in this registry and use data to help improve patient care. And that's where we are not putting in enough. There's 25 good reasons why we can't do it. But then again, all right, that doesn't excuse us from not trying to understand the experiences of many hundreds or thousands of patients we have seen, and the data now exists or is captured and stays holed up in those registries. Do we have national guidelines for sepsis? We talk about the Surviving Sepsis campaign, but are we follow common practices in managing sepsis in our emergency departments? But rather than talking about all this, let's ask ourselves some very basic questions. Who are our patients? How many of you, if I were to ask you, and later maybe question time, how many of you can tell me what is your case mix? What kind of patients do you get? How many, all right, are of what type? Where do they come from? Who are they? What do they want? What do they really need? All right. And I want to separate this. All right. What do they need from our perspective, but they really deserve? And I think this is something that those of us who work in different countries, different jurisdictions, we need to get together in our individual jurisdictions. We need to brainstorm. We need to ask ourselves and tell us every patient we see, whether they be patients or non-paying patients, they deserve the best care that we should be providing. Right? We should never say sorry. That's all we can do. And I have a dictum that every patient who comes to my department must leave, and that is the job of the emergency department. And therefore, to translate it to a slightly larger environment, every patient who enters the emergency medical system must get better. That's our job. That's why we're specialists in emergency medicine. But what's the real truth? What's the reality of 21st century emergency medical care? And this picture typifies what's happening today. Now, is this good medical care? Is this where we would want to see our children being, or ourselves being managed? Let's ask ourselves this question very seriously. And if you're happy with this, fine. But if we aren't happy with this, then we have to do something about it. And we have to do something about it in our own small way, starting with our departments, then looking at the community, at the districts where we work to see how this can be addressed district-wide, then province-wide, then state-wide, and then country-wide. We need to think about what should be the emergency medical care system. And most of us may not disagree that a good emergency medical care system would consist of pre-hospital and in-hospital components. But even more than that, all right, there has to be a preventive element. In the pre-hospital system, there has to be a first responder, a second responder. Whose responsibility is it? Is it the state's responsibility? Is it our responsibility? I don't know. It is everyone's responsibility. But as long as it is even partially our responsibility, we have got to try to do something about it. And there's something I'm passionate about. And I think if we work for the patients see us in the first place, then we must do something about it. Our job, less sick people come to see us. Eventually, we can be thrown out of our jobs and we are not needed. But that would be an ideal world and will never happen. And because of that, today, most of us, all right, our departments become very crowded. Now, here I'm going to come back to Singapore. Now, we are a very small country, one of the smallest countries in the world. And I think that gives us some good things. And I say, if anyone can do anything, because we are very small, we can do it, and we can do it better. And in a way, that's been one of our advantages, that because of our small size, there are many things we have been able to do. But in spite of our small size, I believe, and even if my colleagues don't agree with me, I'll say that we are not doing enough. So we have got to ask ourselves, all right, why are we not integrated yet? At one time, we were more integrated. Today, we are more disintegrated. And why aren't we doing better? So when I talk about integrated emergency medical care, I'm referring to a few things. And I mentioned it earlier. And all of this revolves around the patient. All right? It has to be patient-centered. There has to be prevention. So we as emergency care people have got to see how the diseases that come to us, how they can be prevented, and what can we do about it to enhance prevention. Number one, because our job is not to bring more business in hospitals, regardless of whether we are working in corporate hospitals or in public hospitals. All right, prevention must be very important. Sometimes, in spite of all prevention, still do happen, and that's where there's a need for community first response. Community first response is not the ambulance service, because the people who are next to a person falling sick or getting injured is not the ambulance service. It is a member of the public, and they should be providing community first response. And therefore, emergency medicine has got to pay special attention to how can we enhance community first. Why us? We deal with emergencies. When any illness occurs or when an injury occurs, at that initial stage, if interventions can be brought into the patient or brought to bear on the patient, that patient has a much higher chance of getting better faster and being returned to society to become again economically productive. But if that first response is lacking, then the patient has to wait until an ambulance has to attend to him, brought to the hospital. So we need to have a good community first response system. We also need a good community second response system. And the second response system will be the ambulance services, right? And they must be able to effectively provide good care. Very important, in many of our countries, our so-called emergency ambulance services, so-called emergency because they still call themselves emergency services, they are mainly transportation services, right? But I'll not generalize and say that there are some communities where the ambulance services provide very good emergency care, and we must compliment them, right? They're good in providing emergency medical care. They are good in doing talking about it and trying to improve the quality of their emergency care. Then we must provide good third response. And we are the third responders because we work in the hospital. So we are the people, and they're brought from the pre-hospital environment into the hospital system. So as third responders, what can we do? Are we providing the best level of care possible under the circumstances? Something we have got to think about. In most of our departments, especially those in the public sectors, right, patient flow is a major factor that slows down the delivery of good patient care. And from the tendency is often to admit to the inpatient system in hospitals. If one were to look at public hospitals and private hospitals, that's corporate hospitals, look at the admission rates, you would tend to see that the admission rate in public hospitals is generally lower than in corporate hospitals. I'm not going to that, and I think it's good to have that as a discussion. We have to ensure that we keep patients away from hospitals as much as possible. I know some hospitals will not like it because they thrive on there being more patients, more revenue. These become good. They become patients are profitable for hospitals, but hospitals, all right, also are not the safest of places sometimes, and therefore, if patients can go to community convalescent facilities, all right, that can be closer to their homes, return to their homes as early as possible. In the long run, that is best for the patients. And the patients, the families should be talking to us, feeding back to us so that we can act to see how we can help them. Why is that so? They are the reason why we exist. So this whole cycle of prevention all the way to the hospitals and back to the patient, all right, that I call it should be an integrated emergency care system. So earlier I referred to the need for prevention, and there are many things we can do to prevent. And some of the simple things that some of us get involved in is public training in basic life support, CPR, first aid, all those things. A train first, and one of the targets we had set for ourselves in Singapore way back 25 years ago was that by the year 2020, we'll aim to have at least one trained first responder in every household. It was a target we set. Did we achieve that? No, sadly, we did not. And why? Because so many of us were too busy doing too many things. But we improved a bit. For example, our bystander CPR rate in the year 2001, all right, was about 21%. By the year 2020 or 21, or at least in the last couple of years, I'm told that our bystander CPR rate is now close to 60%. So it's a good improvement from 21% to 60%. and the numbers of people who do CPR, provide bystander CPR through whatever mechanisms, all right, it has increased significantly, and that has also resulted in an improvement in our rate of survival from out of hospital cardiac arrest. It used to be single digit, close to 0% more than 20 years ago. It is now double digit, which is a good thing. But how many of our larger communities in this part of the world can attest to that happening? So we teach people to call the ambulance, call as early as possible. All right. We teach people nowadays, we even try to get ambulance services, all right, to try and obtain data as early as possible and keep emergency departments informed early, because information it's important. Data is important. 25 years ago, this was our response time, that in the event of a cardiac arrest, all right, there'll be a long react, on the average, more than 10 minutes. Then only would someone call an ambulance. And you know that if you hesitate before I call for, right, surviving. All right. And then by the time the ambulance comes, responds, and arrives at the scene, competing with the traffic, all right, it's already nearly 20 minutes. And then CPR started. So the delay from time of arrest, time CPR begins, can be between 20 to 25 minutes. No wonder more than 20 years ago, we had very poor survival rates. And today that has changed. It's a good thing. But how many our other try and move that direction? And that's something we do about it. Again, when we arrive at the scene, if a pre-hospital system, can we bring to the patient all the things the patient will require to ensure maximum survival chances? For example, in the case of cardiac arrest, can we bring in a mechanical CPR device? No, provide the quality of CPR that should be provided. And we have a defibrillator also available on site right away. Can we provide the appropriate airway ventilatory adjuncts to the patient, even the patient at site, so that surviving that cardiac arrest can be enhanced significantly? Short ambulance response times and safe transport, we all know, all right, clinical outcomes. So can our responders do that, ensure that they can respond as quickly as possible, all right, shock the patient early, and increase the chances of return of spontaneous, a better chance of doing something for the patient and trying to keep that patient alive. Again, early on emergency departments, and I'm just showing this to enter the data we obtain when you first into contact with the patient in the pre-hospital, and transmit that data to the receiving hospital, so that every receiving hospital today should know, even before the patient arrives, what kind of patient they're going to get. And because they know what kind of patient they are going to get, all right, they'll be able to prepare their emergency department to receive that particular patient, initiate management of the patient even before arrival, or once the arrives, get together, get to the patient, and manage him in the shortest possible time. And that way help to enhance clinical outcomes. So today we have many computerized systems. We have our own electronic medical record system, and support. We have various kinds of EMR systems. All right, initially well integrated. The National Health Authority has seen it fit that because hospitals are developing their own EMR system, they're not be able to talk to each other. Therefore, hospitals should be able to talk to each other. Why? Because today, this particular patient will come to my hospital, but tomorrow is going to go to your hospital, and the next day to some other hospital. And they should be able to access the patient's information easily. It can only happen if we are integrated. If we have a data management system that's integrated, that allows sharing of data. So again, integration is seen at every level of the care of emergency patients. So that in the future, I don't want to see empty emergency rooms. It means we're not doing our job, right? But at least rooms that are not crowded, that are not teeming with patients to the extent struggling and rushing to provide reasonably good emergency care. That should not be happening. Not only should waiting times for patients be kept as short as possible, right? And why should it be short? Because patients deserve short waiting times. Why do they deserve? Because tomorrow I'm going to be a patient in emergency. And when I come to the emergency department, do I want? Or would I rather sit down and wait for not sure how long before good care can be provided? So if I'm the patient, I don't want to wait. I want to have a team of skilled professionals, all right, who will attend to me, who will interact with each other, and supported by a cadre of trained staff. There's clear direction in their planning for my management. Their feedback to me right away into my family, all right, and I can then get good emergency care. Is that happening in our various departments? And if I require inpatient care, I would not have to wait for an inpatient bed. And the doctor in the emergency department saying, all right, you will need to stay in the hospital. Within 30 minutes, I'll have an inpatient bed available. If everything runs well, I should be in that in-hospital bed within that 30 minutes. And after so that I can out of the hospital, out of that very dangerous environment.
Anantharaman sir, sorry sir, your voice is not audible properly.
Sorry. Can you hear me now?
Yes sir, yes sir.
What I'm saying was that my stay in the hospital should be as short as possible so that I can be out of the hospital and back, all right, being economically productive. And therefore, what can we do in the emergency department to help that? To help that, many hospitals have set up observation wards. Some call that short stay wards. They call it emergency diagnostic or enhanced diagnostic and treatment units, EDTUs, observation units. Why? And they all come with structured protocols. All of this is so that they can see how many patients they can manage within the emergency department and minimize the admission rates into the hospital and get them out of the hospital environment as early as possible. A lot of times, good medical care provided in hospitals, including in emergency departments, goes hand to hand with good patient communication and good communication with the families. And I believe it's very important that families are involved in the care of the patient from the word go, from the time the patients arrive in the emergency department. In the ideal environment, families should not be kept waiting outside while we only interact with the patient. It's good that at least one member of the family is by the patient as much as possible, because that allows us to get as much information as possible and convey to the family what we are trying to do. Unfortunately, because today our emergency departments are very crowded, we cannot afford and we discourage families from being in the emergency departments and ask them to wait outside. Otherwise, there's a big logjam in our EDs. So we need to see how can we create suitable facilities in our emergency departments so that we can all have calm, all right, proper, structured and detailed family and clinical staff interactions. Of course, I don't want to say this over and over again. We all need ED-friendly IT systems, and many of us have sacrificed, all right, good ED care, ED-friendly IT systems, just to all jump onto the bandwagon and be part of a hospital-wide system, all right, with its own attendant problems. Because IT systems don't talk to one another, and we're all told by the hospital that we all must subscribe to the same IT system. We don't disagree with it, right? But we all have problems with our individual hospitals' IT systems. So I'm whining, I'm complaining, but we must complain. If we calmly accept everything that is thrown to us, then we're not being fair to the patients we are managing. So that, and I say all this so that at the end of the day, our patients are happy, they are contented, because then they receive, all right, the best level of care from us, and I think in that way, we will know that we are really doing the work for which we are being paid and salaried. Sorry, can you hear me?
Yes, sir. Yes, sir.
Good, very good. So you see, there is a wide gap between where we are now and where we have to be. And the question we ask ourselves is, how do we bridge this gap? So we always say, I need more manpower. I don't have enough equipment. There are too many patients coming in. And really, the fault lies not in our stars, it lies in ourselves, because the solution lies in ourselves. We can do something about all these problems or these that come to us, and there are opportunities for us to exercise our minds to see how these can be addressed. So we need to look at integration, how we can integrate all our processes so that our patients come together and they have the best experience that can be provided. In all our countries, we have national societies, we have academic colleges, and in how many of our societies do our colleges and our national societies work together? The examples you see on the slide are the society in Singapore and the College of Emergency Physicians. It's part of our Academy of Medicine. So in Singapore, we pride ourselves on our small size, all right? And we try to provide systems, all right, where it's possible to link all these up. But what's most important is that there's a need for the political will, all right, to make sure that the medical evidence that exists, the systems that we have, all right, can come together and we can create practices that are good for the patient. So this picture represents groups of doctors from different public healthcare institutions in the country, and also some of them, one or two maybe in the private sector. All right. Now, today, all these doctors work in different healthcare systems in a small country. How good will it be, all right, that even though we work in different hospitals, and I hear that in the Yashoda healthcare system, you are a single healthcare system, though you have 4 different emergency departments. I'd like to see how, though you have 4 different hospitals in a city or in a state, how you try to make them work together as one common unit. So about nearly 10 years ago, we said, all right, we need to do something about it. And we came out with a document. And one of my colleagues, Professor Stephen Lim from the Changi General Hospital, chaired this effort and came up with this very good document after 2 to 3 years of very hard work, all right, on the state of emergency medicine in Singapore. Have you all not heard that in the US, once a year, the president of the USA comes out with a State of the Union address? All right. So like that, how many of us in our individual countries can come out regularly and say, this is the standard, the state of emergency care in my country today? All right. I've put on my thinking caps, and that was our effort. We did it. It was a very good effort. But have we learned the lessons from all the hard work Professor Stephen Lim and his team, all right, put together? I still feel we have not. And the fault again lies in ourselves. There's a saint, philosopher in India, Swami Vivekananda, who says, arise, awake, stop not till your goal is reached. And I think that is very important for us too, because we all need to open our eyes. Only by opening our eyes, knowing ourselves, shall we even begin to see that light. Must never ask what our Society for Emergency Medicine, our state health department, our National Ministry of Health, not what they can do for us. What I, as an emergency physician, I'm not trying to quote John Kennedy, but I'm trying to be honest here. What can I do for my people, my family, for the patients who come to my department, all right, to emergency medicine, to my patients? Each of us need to ask that question, not just once, over and over again, to remind ourselves, all right, that we exist for our patients. And what we need is a system that's so well integrated in all its various areas, the pre-hospital environment, all right, to that intervening area, what we call the area that is managed by the ambulance services, to us at emergency who lie in the center, to our colleagues in the various departments in the hospital. All of us need to integrate, need to work together, talk the same language, right? Share information, and not just within one hospital, across hospitals, within a community. All of us to pitch in, communicate, try to understand, get involved, and see how we can best, all right, set the tone that will allow good emergency care to be provided for our patients. And we say, I can stand up and proudly say, yes, all right, I am able to provide integrated emergency care. Not giving you answers. I've posed a lot of questions. I've made a lot of complaints. But I thought that should be my intention today. And I'll be very happy to answer questions and discuss with you. But first, if I may, can I ask a question? Can I ask our moderator, Dr. Varma, who comes from the Yashoda Hospitals, how do you try to integrate care within your 4-hospital healthcare system? Dr. Varma?
Yeah. Thank you, Dr. Anantharaman, sir. That was a nice question. So there are multiple ways how to integrate our healthcare system across our 4 branches. So as I said, like first our stakeholder is patient, then our IT sectors, then multi things stakeholders like patient attenders, then our policies, then political, what is our things? So what expectations people have on us, then organizational needs, then many other things. So if we integrate all these things like our skills, everything, communication and all, so we'll try to improve our emergency care and hospital, hospital care as well. Srinath sir?
Yeah, Kiran.
Srinath sir, any inputs on it?
Yeah, at the outset, I'm very, very humbled and thankful to our professor, Dr. Anantharaman sir. I know him since 18 years now, and he's so humble. When I just asked him, sir, can you just spare your time for this webinar? He accepted without any hesitance. That's the kindness of him. And the way he interacts with the residents, even today, it shows his ability to go into and pierce into every mind of the resident and give them what they want. Because emergency medicine is such a specialty which has been grown leaps and bounds with the help of such our professor, Dr. Anantharaman sir. So from my heart, I would like to thank him. And on behalf of Yashoda Hospitals, I would like to thank him. On behalf of Society for Emergency Medicine India, I would like to thank sir. Thank you, Kiran.
Sir, there is a question. Anantharaman sir.
Yes, please.
There's a question. So how do we make emergency care more affordable? This is very important for our country, where most of the healthcare expenditure are out of pocket.
Right. I think good emergency care doesn't have to be expensive care. It doesn't have to involve a lot of high technology. And I want to thank Tamarish for this question. And how do we make it less expensive? And that's where ourselves, we become very important. we should be good role models to be able to take good histories, organize systematic physical examinations. Those clinical skills are very important. Today, sadly, in many communities, I see skills in clinical care are going downhill, and we are becoming very dependent on machines to tell us the answers. That when a patient comes in with chest pain, we don't take a very good chest pain history. We'll wait for the ECG. We'll wait for the cardiac biomarkers. We'll wait for the CT angiogram to give us the answers. But really, see, medical care has become very expensive because we don't trust our clinical skills anymore. Rather, we trust the machine. And so, number one, good clinical care. We need to regain our clinical skills. Number two, when a patient comes to us with a problem, do we need to do every investigation in the book? No. Okay, there should be a rational organization of the investigation resources. And if we can address those two things, then how do we care for the patient? Do all patients need to be managed in an in-hospital environment? I feel no. Some patients need in-hospital care because they need continued supervised care for a prolonged period. These are the patients who can best be managed in an in-hospital environment. I say that because in-hospital care is much more expensive than outpatient care. And the faster we can speed up the movement of patients from inpatient to the ambulatory environment, can all contribute to a lower cost of good healthcare and also good emergency care. Thank you.
Thank you, sir. So really that was a nice presentation, sir. Anantharaman, sir. So we learned many things out of this unit. Is quite interesting for all of us. So out of all these things, there are a few things, sir, like a short ambulance response time, then early evacuation, then easy sharing of cross hospital information, then good communication skills among ourselves. There are multiple. Then one interesting thing, sir, which I would like to tell you. At least one first responder in each and every household. So that was a nice one, sir. So we will try to implement here in India as well. We'll try to do as much as we can. So then I would like to ask you one question, sir. How do you manage overcrowding in your department?
Right, it's a very difficult question to answer. Thank you for that question. Now, to me, the major cause of crowding in the department is access block. That's in my department. But the situation had not always been that way. Way back 30 years ago, or let's say in the mid-1980s, that's 40 years ago, the main cause of crowding was patients coming in. Up to 50% of those who came into the department were what we refer to as non-emergencies. But in the year 1985, we started a series of public education programs, all right, on educating the public as to what is an emergency, what is not an emergency, who should be coming to emergency departments. And these were sponsored by the state, these public education programs. And each time we conducted these programs, roughly about once every 2 years in those days, all right, they'd be totally funded by the state. And that resulted in a step-by-step manner in the number of non-emergencies coming to emergency departments coming down significantly. So that today, on the average, throughout Singapore, at least in the public healthcare system, the number of truly non-emergencies coming to our emergency departments has now come to less than 10%. So it has been a long journey, right? But it has been very good. But however, the problem that has come up over the years is not so much the input. We can handle the patients who come in. It is the output that has become our major problems. In the old days, we used to double deck our wards. We never had a problem of crowding in the emergency department. I remember 40 years ago. All right, but today is different because today you cannot double deck in the ward. All right, every patient must have his separate space. And because of that, where does the traffic jam occur? It occurs in the emergency department. And that has become the major area where crowding is occurring. And I think at the same time, patients are staying longer in the emergency department, longer because we order more tests, because we want to do more things, which is good for the patient. But unfortunately, they're also waiting for many hours for a bed, which becomes a major contributor. So we now need to see how we can address the output issue and make our emergency departments more efficient in our processes. I think that has become the major challenge.
Thank you, sir. So there is one more question. Is there any advantage of step-down ER? Example, monitoring or observation rooms for patients received in initial management in ER, so that ER beds can be kept ready for the new patients. And how far is this practical in India?
I think step-down units like observation wards or EDTUs or short stay wards, it's a very good concept and has been effectively used in many hospitals throughout the world to help to cut down in patient admission rates. All right, because less patients in the hospital, less excess block. So I think it's a very good idea. But it mustn't be that every emergency department patient who comes in must naturally go to an observation ward. So we mustn't pass crowding. And I've seen that also happening in some hospitals, right? Where they keep the patient for a short while in the emergency department, then automatically transfer most of them to the so-called observation ward, where they stay for many, many hours. So our job is not to pass the buck to the observation ward, but to ensure that there are clear criteria for who should be sent to an observation ward. If patients do go there, what are the protocols of care that should be followed so that they can be optimally managed, all right, and that will allow the bulk of these people to be discharged home within 23 hours. So discipline is required in the management of these observation units. Yes.
Thank you, sir.
Can I ask a question? Can I ask a question? What is being done in India to address the growth of the first cadre of first responders?
So I didn't get you, sir. Sorry, your voice is not good. I didn't get you.
What is being done in India to build up the pool of community first responders?
So to improve the first responders, the community level. So actually, you have been conducting many mega B-list events, sir, directed towards community. So like, especially for the non-medical personals. So we are going towards school children and college, engineering colleges and all. Then community levels, we are connecting various programs as a part of corporate social responsibility on behalf of Yashoda group of hospitals. So if you ask me the number over a period of last 1 year, 2 years, so I have trained nearly 10,000 people, non-medical persons, not the medical person, non-medical personals. So this is our day-to-day process and programs what we have been conducting to improve first responders at the community level.
Right. Okay, thank you. I also see a question there from Dr. Angelina Ang, and Angie has asked, she asked, how might we reconcile the need to subspecialize and the need for holistic integrated care? One question, and what may be the implications in terms of training of emergency healthcare providers, in terms of organization of systems and infrastructure? Okay, I think this is a very good question, a very important question. The need to subspecialize. Why do we need to subspecialize? Because all of us want to do more for our patients, and to do more for our patients so that they can get better, faster, and have better outcomes. So to do that, we need to have experts, build up the expertise within emergency medicine. But when we subspecialize, then the question becomes, we only delve into our own subspecialty interests and forget about providing general emergency care? I think not. All of us are generalists, but also each one of us may have our own special subspecialty interest. And when we have our subspecialty interests, it is our job to push these subspecialty interests as much as possible within the department, so we can be subspecialists and yet good generalists. And so I feel that's the approach we have to take. If we take that approach, then we'll not be compromising on providing overall emergency care and running the emergency department, and still pushing forward the quality of emergency care in the various subspecialty areas of emergency care. Angie, I hope I've answered your question.
Yes, sir. Thank you. Thank you, sir. So I hope no questions so far. Yeah. So no more questions, sir. I think we can conclude. Dr. Srinath, sir.
Yeah, we can conclude. We can conclude. Thank
Yeah.
you. Thank you.
Uh,
Thank you.
Thank you, Dr. Srinath, sir, for creating this platform of a webinar to spread our knowledge among ourselves. And I thank Semi Board and by for your support. I thank Yashoda Group of Hospitals and Management for your continuous support. And last but not the least, Dr. Anantharaman, sir. See, really, it's our privilege to have you here for today, sir. Thank you so much. Thank you so much for your time and enlightening on the fragmentation, integration, about all these things. And all the viewers of this webinar, I thank you. Thank you, Anandal. So we'll catch you up in the next webinar. Thank you, sir.
Thank you very much.